What is opioid use disorder? This is the most current nomenclature, the name used to describe addiction. The medical community and psychiatry community are getting away from the words dependency, addiction, abuse, and replacing it just with a general term that covers all of it, and this is opioid use disorder. Another term is opioid misuse. This encompasses all types of drug use that involves opioids. So when I say opioids, I mean drugs like codeine, dextromethorphan, which is in cough syrup. Those are the gentle ones. Then there's tramadol or Tramacet, and then Percocet, Vicodin, oxycodone, OxyContin, and finally the heavy hitters like morphine, heroin, and finally fentanyl. So these are all the main drugs of abuse that are in the opioid class. And if a person is using them, is it possible for a person to use these sporadically without developing some sort of dependency of some sort. These drugs are so powerful and so strong that it draws a person into the addiction spiral for most people. A casual user is very rare, especially with the heavy-hitting drugs at the high end of the spectrum, but some people can use casually things like a half a pill or any amount of pills of Percocet or Vicodin. But what happens for most people is they may use sporadically in the beginning, and they progressively use more and more. This is the problem with these class of drugs because they're safe in short-term use. There's nothing wrong with using them as prescribed up to a week or so for an acute treatment of acute pain. But what happens is people end up they feel well on these drugs. It's not only helping their physical pain, but can also help their emotional pain. It's sometimes a stress reliever, and I actually called it a happy pill. I felt happier and more awake when I was taking Percocet. So like I said, the problem is that most people cannot control their intake. They go through withdrawal fairly quickly off these drugs, so should they cease taking it, they would feel uncomfortable generally within 24 hours or so. The rare user who can use once in a while, like I said, is very rare. So for the most part, it is considered a disorder because the person is requiring more and more of the medication to achieve the same effect. So this is what we call tolerance, and they will go through withdrawal should they stop taking the medication, and this is called dependence. So those, all of the above can include people with opioid use disorder because this describes the dangerous addiction spiral that affects all aspects of their life. It could be, for most people, it's a deteriorating spiral where they require more and more amounts of the drugs to achieve the same effect. But the problem with that is that they will go through a more serious withdrawal because of the higher intake of the opioids. So this is why it's a disorder. Not to mention all the complications it has on a person's quality of life. In the beginning, when they're going through acute withdrawal, they can start missing school, work. They lose interest in activities that normally gave them joy. There's deterioration of relationships with loved ones. They lose their friends. They burn bridges with people. So this is a general broad strokes description that I'm giving, but this is my best way of explaining why this is a disorder and why it belongs under this terminology. So to summarize, opioid use disorder or opioid misuse describes the whole gradient from somebody who's using sporadically, like as a weekend warrior, somebody who rewards their behavior or working hard during the week, where this is at the light end, and at the heavy end is that this person can start developing tolerance. They can increase their use, and before they know it, they're addicted, meaning that they're dependent, meaning that if they were to stop, they would go through withdrawal and feel very uncomfortable. And this is what perpetuates the spiral of deterioration in the addiction. So finally, the worst end of the spectrum is somebody who's using the more potent opioids, things like morphine, heroin, and fentanyl. These are more dangerous because they're more potent and they work more rapidly. People who are using heroin tend to use intravenously. Some people do smoke it, but it's the intravenous abrupt introduction into the body that causes problems. They get high quickly, but they come down quickly. The same thing goes on with fentanyl. So this helps demonstrate why it is that opioid use disorder covers a wide spectrum of disorders and use. It is a disorder for almost all people who are using them, with the exception of some people who can curb their use, and people who are chronic pain patients who do take their pain medications as directed according to their doctor and try to wean down once they're feeling better. What is the treatment for opioid use disorder? The best way that's been proven now, this is evidence-based medicine, is to start them on a bridging medication called Suboxone or methadone. Methadone is well known in the past. This is a liquid form of an opioid that is very long-acting but doesn't quite create it helps to remove the craving that occurs, and because it's long-acting, the person is able to focus ideally on their life and not be chasing the drugs and going through withdrawal. So it enables the user to get off of their drug of choice and onto a more stable opioid. The other one, as I mentioned, is Suboxone. This is otherwise known as buprenorphine combined with naloxone, which is the antidote that we commonly hear of. But in this situation, it's just a very small amount of naloxone, but a larger amount of buprenorphine. Buprenorphine is called an opioid antagonist, and so this satisfies the opioid receptors in the person's brain. What this translates to is that it avoids putting them into withdrawal. They can go from their drug of choice, let's say Percocet, Vicodin, or even fentanyl. They would cease taking the medication, cease taking their drug of choice, and be switched over onto Suboxone. There's a little bit of a period here where they need to go into withdrawal first before the Suboxone will start working properly, but that's getting into the smaller details. The more important thing is that they're switching over from a drug of choice that is dangerous, including heroin, for example, with injectables, can be very dangerous for them. And they're starting on Suboxone, which gives them, satisfies the opioid receptors in the body so they don't go through withdrawal, and they're able to get their mind back. They're no longer a prisoner. They're no longer a slave to the high of the drug and going through withdrawals. They're now able to start coping in life and get into recovery. That being said, it's best to initiate a wean or taper of whether it's methadone or Suboxone. Some people do stay on it for the rest of their life, but I think it's best to try to wean slowly. The rule of thumb is 10% per week. And the final 10% can be very difficult, whether it's methadone or Suboxone. And those are the cases where some people do stay on low-dose lifetime therapy. But this is the best way to treat the short term, okay? This is just the short-term solution, to get onto opioid replacement therapy, Suboxone and methadone. The longer-term treatment, though, is to engage in lifestyle changes. And this is best learned in a rehab, in my opinion. Rehab's not for everybody, but it's certainly worth a shot for somebody who's never been before. The idea is that it gets them out of their normal life routine and they can abstain from taking their drug of choice, start on the opioid replacement therapy, and now their mind is open and start learning the behavioral changes needed to have to enhance the chances of a positive, enduring, lifelong recovery. So these are the things that are learned in recovery, in rehabs. 12-step programs can be helpful as well. There's other types of peer help groups out there. And the idea, though, in the rehab is to live their life, go through stresses like everybody does throughout life, but at least they're buffered from major stresses. They're not brought into situations where they can use again. Ideally, the rehab would be drug-free. That's the idea. And to go through this as a stable way of living their life and being able to manage with stress and coping through life stresses without relying on the crutch, which is their drug of choice. That's the best benefit of rehab, is to learn new coping mechanisms. And it is said that 85% of recovery is really learning the behavioral changes, like I just said in rehabs, and the other 15% is abstaining. Finally, it's some people are not cut out for rehab, or they're just totally against the idea of going. And in this situation, they could just continue on opioid replacement therapy indefinitely. The other options for them, though, is to do outpatient rehab, so they're going in the daytime and going home at night. That's certainly a possibility. And there's nothing wrong with engaging in a 12-step program on their own. But to increase the chances of an enduring recovery, I would highly suggest that they do get involved with some sort of rehab facility in some way, shape, or form. So to summarize, the treatment for opioid use disorder is complicated, yet is simple. In the short term, it's to get onto the opioid replacement therapy, whether it's methadone or Suboxone, to stabilize them so they're not going through withdrawal. And then the next step is to engage in a program of life-changing stress management, ways of changing their lifestyle that's taught in rehabs. They're the best at doing this, to start with that other 85% of life, other 85% of their recovery, so that this can introduce new skills, new tools to be able to cope with life stresses and to have an enduring recovery.